Hello and welcome to this episode of Trache Talk. We're continuing our interview special series in 2025 and Lina, our medical student volunteer, is chatting this time to Professor Cliff Shelton. Cliff is Professor of Perioperative Medicine and Anaesthesia at the University of Lancaster. Cliff also works as a consultant anaesthetist at Wythenshawe Hospital in the south of Manchester. Cliff has various research interests, mainly focused around quality, safety and the environmental impact of healthcare. With someone like Cliff around, we had to get him involved in some of our NTSP projects. And so I'm going to hand over to Lina and let Cliff tell all about what he's been up to.
Hello and welcome to Trache Talk, where we're diving into the story behind the GIFT project. GIFT stands for Guidance for Tracheostomies, and it's a new device designed to make tracheostomies more accurate, precise, and ultimately safer for both patients and the clinicians performing them. In this series, we're speaking to the incredible team behind the project to hear firsthand how it came together, from design and engineering to clinical research and frontline impact. I'm delighted to be joined by Professor Cliff Shelton, who led the qualitative research behind the device. Cliff, thank you so much for being here. It's really great to have you. To start us off, I know you're an anaesthetist, but also a qualitative researcher. So I was wondering if you could just tell us a bit about that background and what your typical day-to-day job involves.
Yeah, so I'm one of, I think, quite a small number of anaesthetists who do qualitative research as part of my job. So I split my time between working at Wythenshawe Hospital in Manchester, where I'm a colleague of Brendan McGrath, who's the chief investigator on the study. Brendan's an intensive care doctor primarily. I don't tend to do intensive care. Apart from in pandemics, I work in the anaesthetics department. So my job in that respect involves a combination of emergency and planned work. I do a bit of obstetrics, do a bit of the emergency list, and I do some out of theatre work and some orthopaedic trauma. So that's me as a clinician. As a researcher, I work at the University of Lancaster, where I have some educational aspects to my job. And some leadership roles, but research, I do about a day a week of research, something like that. And most of what I do involves qualitative methods. So qualitative methods tends to deal in unstructured data. So, for example, it could be things like conversations or observations of practice. And the sort of research that I'm interested in doing involves understanding how people do what they do in the workplace. So things that involve talking to people about their work or even observing practices and seeing what we can learn from that.
Right, okay. It sounds like a really nice mix of both hands-on clinical work and a good bit of academic stuff as well, but that's still related and tied back into the workplace. So I can imagine that being quite a satisfying mix. How did that lead to you being involved in the GIFT project, and how did you come to be involved in that? Was there anything in particular that drew you to working on this project in particular?
So I think one of the things that qualitative research can bring to anaesthetic practice or, medical practice in general is it's really good at understanding what motivates people and also what kind of underpins some of the actions that they take in practice. So in anaesthetics and intensive care, we're really interested in patient safety. And one of the things that helps us to understand how to make patients safe is to understand sort of why people do what they do. And if you can understand that, you can maybe think about implementing interventions that could make things safer or higher quality for patients. So one of the things that I'm interested in is the sort of understanding how clinical practice and technologies interact with each other. And the term technologies is often taken to mean quite a variety of different things. So, for example, it could be something like a piece of tech, like a device that might come out of a study like GIFT. But it could also be something like, say, a checklist or or a drug, for example. So, lots of different perspectives on that. And one of the things that qualitative research sometimes allows you to do is to zoom in on how people deal with existing technological challenges and to think about how they might use newer technologies. So in my, background as a researcher, in my sort of back catalogue, I actually did a study about ultrasound. It's the use of ultrasound in putting in central lines. That was when I was an academic clinical fellow. And I think there's quite a lot of parallels between something like that. It's an assistive technology that helps to guide putting a needle into the right place in the case of central lines in someone's vein, and what's being done here. And then drawing on that, I've done various other bits of research that look at how clinicians interact with technologies. So I think, Brendan and I talk quite frequently about the work that each other does. We've collaborated a couple of times on similar things. And so really pleased to be asked to be part of this work because, it's an exciting development, but aligns with some of the stuff that I've done already.
Yeah, thank you. That's such a great answer. I think it really put things into context. And it's interesting to hear that you've already worked on something similar in terms of like an assistive device and the role of qualitative research in sort of understanding why people do what they do and sort of improving and helping sort of patient safety. You sort of touched on my next question, which is, could you explain the goal and purpose of qualitative research when it comes to bringing a medical device into practice? I think you've sort of explained that, but if there's anything you want to add.
Well, I suppose I can just say a few words about like practically what gets done. So the thing that we're here to talk about today is a piece of work which is pretty much finished now. So we're kind of writing the paper and sort of putting the finishing touches to it. But what it seeks to do is to sort of map out the landscape as it already is in terms of, what are the challenges that people encounter when they're putting in tracheostomies on the intensive care unit, and what have those clinicians learned about the introduction of new technologies. So there's two things that I think we can get from that. One is it can help our colleagues who are dealing with the design side of the project to actually get a really nuanced understanding of the challenges that are currently bugging clinical colleagues, and therefore not miss any opportunities in terms of developing the device. But also we've got some interesting cautionary tales about the introduction of technologies into the critical care setting and how sometimes they don't always go perfectly smoothly. So I'm hoping that between those two bits of learning, this should put my colleagues who are responsible for other aspects of the project in a really good position to make the best of the time and the expertise that they've got to focus on this. The other bit, of course, that we can add is at the other end of the spectrum, when something has been developed and has been, either introduced, shown to people or even introduced into practice, we can go in and observe what's actually going on or talk to them about their experiences of use. And that's something a bit different. But at this stage, we're sort of mapping out what the challenge is that we have to deal with.
Right, okay. And when it comes to gathering the data in particular, what was your approach, or who did you speak to, and what were you hoping to understand from those conversations?
So this particular study, this relied on two methods of data collection. One was semi-structured interviews. So semi-structured interviews is where you have an interviewer with a list of things that they'd like to talk about. So that's the structured bit. The semi bit is that if a respondent says something that's particularly interesting, the reviewer is given the license to kind of pursue that and, tweak the questioning according to what the respondent has to say. And so most of our data collection was that, but we also did a couple of focus groups. So focus groups is where you get, in this case, colleagues in the same place at the same time, and you ask them to focus on certain areas and talk together about them. And you're doing something subtly different when you do those two different kinds of data collection. The semi-structured interviews are about an interaction between two people, the interviewer and the respondent, and they're really good at diving into depth about what that individual respondent thinks about a certain topic. Whereas focus groups, they're about exploring areas of consensus or areas of controversy amongst colleagues. So if you've got a few people asked to focus on a particular topic and you find that their views are divergent, so they disagree about things, that tells us that there's something of interest there that might need a bit of unpacking. Whereas if they all agree, it tells us that maybe there's less, controversy in a certain area. So they're doing something slightly different, and we find those both of those things are useful when it comes to understanding an issue like this, which is kind of by definition quite complex.
Right. Yeah, it sounds like a good mix of two types of research to get more comprehensive view of people's ideas. All right, so I think since you're both an anaesthetist and a qualitative researcher, and you've used two types of methods in terms of semi-structured interviews and focus groups, there's quite a unique perspective both that you bring and also both of those research methods bring. Have you found that your clinical experience has shaped that approach, or the feedback that you've gotten from clinicians and patients? And do you think it helps when it comes to understanding the nuances or feedback? Are there any drawbacks or blind spots or biases?
So, I mean, qualitative research has always, you are both the researcher and, if you like, the instrument of analysis. So, you know, a lot of qualitative research uses something called inductive thematic analysis. That's the approach that we're taking. And it starts off with sort of reading through the transcripts of the interviews and ends up with sort of summarizing everything that's in those interviews in terms of themes. And so the process, very briefly, you go through with familiarizing yourself with the data. You assign little fragments of data to what are called codes, and then you might coalesce some of those codes together to make themes. So it's a way of summarizing lots of unstructured information. But the analysis, you know, happens in your head and in the head of your research colleagues. And so it would be ridiculous to deny your influence on the research. And there's actually something called reflexivity in qualitative research, which kind of encourages researchers to have a proper think about what they bring to the study and, you know, whether, you know, how to use that, but also maybe how to guard against the potential for it to lead them down a particular path. So, for example, for me, as I said, I have done intensive care, both in my training and as a consultant in the context of the pandemic. And so I maybe don't have the same degree of exposure to percutaneous tracheostomies that somebody like Brendan would do. But I have got my particular experience of doing it, and I've got a particular perspective that I have, which is to say that as an anaesthetist, I would tend to be given the top end of the patient. I'd be using the laryngoscope and positioning the tube and liaising with my colleague. We also had some other researchers on this. So Matthew Moran and Alex Doriani, they're two resident doctors who have been working on this study, and both of them have worked in ICU, but at in a different job role and at a different level to me. And so all of us, almost one of the first things you have to do when you set out on analysing this data is to think about where you're coming from, think what that gets you. So, for example, it's not always a drawback that I understand the practice of, you know, putting in a percutaneous tracheostomy, but also it's really helpful when it comes to kind of understanding what people are talking about if you're conscious of where you're coming from. And so it would be natural for me to be really interested in people's accounts of how to deal with that top end of the tracheostomy and maybe less engaged with the stuff that I don't normally do. But if you've already kind of thought about that and you've discussed it as a team, then it helps you to just check yourself if you feel like you're going too far down the path. So I would say, of course, it shapes it. It's often a good thing that it does. The way to avoid falling into the trap of just repeating your own biases is to be clear with your colleagues about, you know, where you're coming from and what, you know, you each bring to the analysis, but also be clear with your readers. So, as I said, we're in the process of writing this up. And one of the things that we include in the write-up is a brief description of, you know, the analytical process, but also, you know, our sort of reflexive approach to that.
Right. Thank you so much for explaining that. It's really interesting to hear that that is actually considered even before you go into the research, and sort of it's mentioned in the paper itself, and you sort of have discussed it with your other colleagues and have ways to sort of leverage it, but also guard against and check yourself against going too far down a particular path, like you said. My next question is a bit, again, about the research, but in particular about patients. So I was wondering, have patients been involved in any part of this research process for the device? Or do you see a role for their perspectives in shaping how technologies like this are developed and evaluated?
So I think in common with virtually every NIHR-funded research project, this study as a whole has got a combination of meaningful patient and public involvement, which, generally involves taking an idea to patient and public stakeholders and asking them what they think about it and helping to, refine the process, but also patients and members of the public embedded within the investigative process. And also in the study governance. So I think that's, almost an expectation now of the funder who's paying for our study, that you can't just go off and do healthcare research without involving the people that healthcare seeks to help. So in terms of, has the study design as a whole had input from patients? Yes, and at multiple levels. In terms of this particular work stream, we haven't involved patients as respondents to this study, and that's because the aim of this piece of work is to understand the perspectives of health professionals, not the perspectives of patients. So that's not to say that this isn't relevant to patients, but that's just not what we're trying to find out.
Yeah.
Likewise, we haven't utilised patient co-investigators in terms of understanding the data here, and I think that's probably fair enough, given that quite how technical some of the descriptors are. It probably makes a lot of sense to have people who have got medical training doing the data analysis. But one thing that we will be doing is folding the feedback from this piece of work in with the rest of the work and making sure that the project as a whole keeps its focus on patients and the public. Because at the end of the day, if we end up developing or producing something that patients feel is in some way problematic, then we won't really be serving the primary needs of the healthcare service, which is to look after patients.
Right. So not in this particular stage of the research, but throughout the whole process, it has been considered as the priority, and it will be sort of checked against that and made sure that it's sort of serving them at the end, which makes sense to me. Just moving on to the content and findings of the research behind GIFT itself, can you give us an overview of the findings and the research that you've been involved in for this device?
Yeah, so in summary, this was an interview and focus group based study. We interviewed 26 clinical colleagues. So these comprised all kinds of different professionals. There was a preponderance of doctors, which I think is probably fair enough considering who does tracheostomies on the ICU. But we also wanted to include the perspectives of those people who are involved in the procedure, maybe more peripherally or in a support role. So we included, for example, nurses and healthcare assistants, as well as medical staff. We were aware that tracheostomy practice might be different in different types of institution. So we sampled from 3 different types of ICU. So one of them is a general acute ICU that accepts medical, surgical, and also some burns patients. So it has a small amount of, sort of specialist practice. One of them was a cardiothoracic intensive care. So that's pretty much all specialised. And it also has an ECMO service. So it takes a combination of post-operative patients who've had cardiac and thoracic surgery, but also people who've had serious problems with their hearts and lungs that require support that a normal ICU can't supply. And then an intensive care unit that's in a district general hospital, so a more generalist environment. So those 3 places, which you can never be, fully representative of the whole of intensive care, but we felt that by bringing in that kind of teaching hospital, subspecialist and district general hospital ICU, we'd get a perspective that was transferable to other settings. We did 26 interviews. We also did 2 focus groups. I won't go through all of the questions, but fundamentally, we were interested to kind of understand the processes, the decision making, also quite a zoom in on the procedure of tracheostomy, and then to get some accounts of those sort of technology and introduction experiences of colleagues. And we used a combination of questions just asked verbally, but also some sort of elicitation type techniques. So having a picture of an ICU bed space with, all of the various bits of machinery and so on around it, which kind of allowed people to have a frame of reference to discuss some of the practical aspects of the procedure, and also helped with some of the communication so they could point to bits of the image and say, this is the bit that, where we struggle to get the space to do whatever it happens to be.
Okay.
Whatever. So it was about drawing information out on the respondents' own terms. And so each of those discussions was transcribed, so written down in text. It was anonymized. And then we went through the thematic analysis process that I've described with you. And we have arrived at 6 different themes, that each of which tell us something about the tracheostomy process. So the first one, we've talked about gaining skills and keeping them. And this combines 2 things. One of them is around how the predominantly doctors in training will acquire the skills to do a tracheostomy in the first place, either in terms of the top end or in terms of the, if you like, the sort of surgical bit, putting the needle into the neck and putting the tube in. And then the second bit about that is how, once somebody becomes a consultant or becomes a SAS doctor who's working on the ICU, how do they manage to hang on to those skills? And both of those things are influenced by the fact that tracheostomies, although there's lots of them nationwide, actually for an individual person, it might be some months in between the first tracheostomy of the year and the second tracheostomy of the year. How do they develop and how do they maintain those skills? And we talked about, some of the ways that technologies get used in terms of doing those. So, for example, things like, video laryngoscopes, another assistive technology of which there's lots of discussion in the ICU literature, might actually help with some of that, because it means that the person who's doing one bit of the procedure can show what they're able to see to a senior colleague and can acquire some advice on what they're doing.
Okay, yeah.
But that was recognised as a skill. It's something that's difficult to learn, and it's difficult to maintain a skill in doing it. The second theme was called how people, equipment and the environment interact to keep patients safe. And this is, related to something called ergonomics. So this is kind of like how people and then people and stuff interact with each other. And this was important because, particularly thinking about our study as a whole, and the potential to develop a piece of technology, we were interested to know about how, or interested to hear about how people interacted with this kind of plethora of technologies that are already out there. So, this incorporated things like what might be called human factors. So, who leads the team, who follows, and, and also the stuff around the kind of ergonomic makeup of a bed space and how that can help or hinder the procedure. Some of the things that I thought were quite interesting here was around the dual roles that some people occupy. So, for example, the senior intensive care clinician might be the most appropriate person to be making the hole in the front of the patient's neck, but might also be leaned upon to lead a team. And, right. There's a tension there, because traditional teaching would sort of tell you that if you're the person who's leading the team, you should be stood back, maintaining this kind of helicopter overview.
Yeah.
And that's kind of where the realities of work as done come clashing up against, the sort of idealized version of work that's sometimes talked about in the literature. So I thought that was quite interesting. The third theme was all about the dangers of tracheostomy insertion and how to prevent them. And, some of this was kind of a selection of war stories of things that had gone wrong with, tracheostomies. And, it kind of underlines the usefulness of assistive technologies to some extent. And hopefully, our colleagues working on other bits of the study will find this useful. The sort of accounts of things that people have encountered problems with, but it also kind of brought in this another tension, if you like, between if you're going to put a needle in the front of someone's neck, you might end up damaging something, and so. The instinct might be that if you were concerned about that, maybe you shouldn't do it. But then if you delay somebody's access to a tracheostomy, you delay their weaning from mechanical ventilation and you commit them to a longer ICU stay. So there's a sort of, patient injury by commission, by doing something, but that's pulling against the risk of patient injury by omission, by the risk of not doing something. Right. And so I think that was really interesting to kind of get inside the heads of our ICU colleagues and have a think about, risk as they see it. And also you can't really overestimate the impact on the individual of, if you're the person who causes the harm, how that might feel, or how that might, impact on you and the team. The next theme was about variations in how to plan and do tracheostomies. And, this sort of relates to the previous one in terms of individuals' appreciation of risk. But it gave us some insights into how people plan and execute the procedure. And one of the things that was interesting there was around the sort of decision-making process. So when might people feel that a tracheostomy is not suitable for a patient, or the patient has to go to the operating theatre? It also underlined some variations in procedural techniques. And again, thinking about how this integrates into the wider project, it's really helpful to understand that there's not just one way of doing something. Actually, there's lots of different individualized practices. And that if something's really going to work for colleagues, it has to work with, lots of different ways of doing the same thing, as opposed to there being just one standardized method. So I think between those first 4 themes, we've got a nice comprehensive understanding of, how people approach tracheostomy in the real world in terms of how it's been recounted to us. And then our last 2 themes really relate to things like, the role of assistive technologies. So those are called What Assistive Devices Tell Us and How, and also the benefits and pitfalls of introducing new technologies in a complex environment. And I think those 2 really tell us something about just how much tech there is in an ICU, and how that brings challenges as well as benefits. And the information overload is a sort of constant risk, and that we might need to guard about. And some of the information that kind of came from the respondents who were talking about assistive devices really underscored that simplicity and clarity of information presentation is important, particularly when you've got lots of other things going on in your head at the same time, and all those other things that have got displays and beeps and alarms on them as well. And the thing around introducing technologies in a complex environment, that told us, that was sort of like a discussion of some of the failed technological introductions and some of the things that, let them down. And the thing that kind of struck me as someone involved in a technology development project was kind of, if you introduce technology for a technology's sake without thinking quite carefully about the problem that it's trying to address, and also the way that clinicians work, then that technology is likely doomed to failure. So, I think it hopefully hints at the idea that we're doing the right thing by going into clinical workplaces and trying, putting a significant amount of effort into understanding the problem that we're trying to address.
So looking back, I'm curious, from your perspective, what's been the most rewarding or valuable aspect of being involved in this work and the GIFT project?
So I think from a personal standpoint, it's always a privilege to be given a little window into other people's work. As I said, I've done a bit of ICU in my training and, in the context of COVID, but I wouldn't by any means count myself as an expert in it. And so just having some insights into this procedure and what people think about it, and some of the really honest accounts about people's anxieties. You don't get that a lot from, in particular, senior colleagues who, always seem really impressive in the workplace, and they are really impressive. But it's really interesting to hear what's going on in their head and to think about how we might be able to help address that. So I think that's always a privilege. The other thing that I've found really inspiring from a whole project point of view, though, is being involved with such a diverse, multidisciplinary group of people. So we've got everyone from, clinicians to computer experts to, product designers all working together on this one project. And it's just a real joy to be able to contribute my little bit into a project that takes the best of all these different disciplines and hopefully is going to lead to a big benefit in patient safety.
Yeah, definitely. I think it's been great even meeting you all and seeing the different backgrounds and routes that people have taken into this work. So I think that's a very reflective point, and I definitely agree. Even from the little that I've seen, it's been quite inspiring. Well, that brings us to the end of my questions, Cliff. It's been an eye-opening conversation and you've shared so many fantastic insights. Thank you so much for your time and for diving deep into all the considerations behind the research for medical devices like GIFT. I really appreciate you sharing this knowledge and perspective with us. That brings us to the end of this episode of Trachea Talk. Thanks so much for listening, and stay tuned for more conversations with the incredible team behind GIFT.
So that's it for this episode. Thank you to Lina and Cliff for their time and help in pulling this episode together. Please note that the comments and opinions of our guests and editors do not necessarily reflect the views of the organisations for which we all work. Please leave any comments as ever in the chat and social media function of the website. I look forward to seeing you again next time for the continuation of this interview special series.